7 o'clock, so we're gonna go ahead and get started here. So I was talking to our fellow Dr. Patel this week, and we were just talking, and I was asking him, why do we need to know different causes of leg swelling? And I was, just posed a question to him, isn't it enough that we have the ultrasound, and if it's positive for venous disease, then we treat it. And then if it's negative for venous disease, we just, send it back to their primary care doctor. Obviously, most of you guys know that it's not that clear cut. First off, only an estimated about 30% of patients with sonographic reflux are going to develop swelling. Second, we all know that patients dedicate their time, adjust their schedules, invest copays for our consultation. So we should provide some value to their appointment, regardless if they're positive for venous disease or negative. And winning our referral base largely depends on how valuable of a resource we are when it comes to evaluating their patients. I tell my clinical staff, we see patients for 3 reasons: leg swelling, leg discomfort, or something visual that is affecting their leg. Sure, there's some overlap between these categories, but knowing how to evaluate leg pain, visual abnormalities of the leg, and in this case, leg swelling, we can give the patients and the referring base a differential that is very satisfactory. We also need to know that this information is important so we don't miss serious medical conditions. And we also need to know this so we can best manage patients' expectations. Obviously, lower extremity edema is not life or limb threatening in itself, but in rare cases, it can be a clinical sign of a serious medical issue, such as a DVT or cellulitis. It could be the first clinical signs of systemic disease, like heart failure or kidney disease. And it can also be caused by venous outflow obstruction from a pelvic or abdominal malignancy. So there's definitely some serious conditions that we need to be aware of. Luckily for us, more common causes of lower extremity edema are not lethal. So I tell my patient, look, no one ever dies of a swollen leg, but it can affect how their footwear fits. It can affect mobility and stability, and it can affect the health and the integrity of the skin. Obviously, we see a lot of skin infections, skin rashes, skin discolorations, and even skin ulcerations due to leg edema. Also, if patients' legs are swollen and they're injured, we see delayed wound healing and subsequent infection as well. So leg edema also can affect the appearance of the legs, which may influence how people dress or how comfortable they are participating in certain social situations. So leg edema in itself may not be life or limb threatening, but it can be a quality of life issue, and it can lead to other medical issues. So let's start with some salient points that we all should know. Obviously, the most common cause of leg edema in older adults is chronic venous deficiency. However, the most common cause of leg edema in menstruating females is going to be idiopathic edema. Most common under the radar cause of leg edema is pulmonary hypertension, often associated with obstructive sleep apnea. And we should all recognize that leg edema can occur regardless of any underlying disease state, like muscle injury, dependent edema from prolonged standing or sitting, and even excessive salt intake. Now, we just talked briefly about there are some concerning causes, some systemic diseases, DVT, infection, malignancy. So in certain patient populations, we need to be extra careful when we evaluate these patients. And I know you guys heard me say this before, but when we're 10 years old and our leg swells, it's one thing. When we're older than 10 and our leg swells, I tell everyone you have a swelling pie, and there's different slices of that pie. So think multifactorial when you're evaluating patients with leg edema. And don't discount medication side effects, which we'll talk about. Now, edema is defined as a palpable swelling caused by an increase in interstitial fluid volume. We need at least 2.5 to 3 liters of interstitial fluid to have it manifest itself clinically. I know we've all had patients come into our offices and said, oh, you know, my leg just started swelling yesterday. Well, maybe in some cases, but in most cases, there's a low level of swelling that's developing for a longer period of time. And it only reaches that threshold of accumulating an interstitial volume of 2.5 to 3 liters to where we can now visualize it. Now they get their sock line, you know, now it's more evident. So think of, you know, this is often harmless. Think of that this requires a broad differential, and it's often not just one thing, it's multifactorial. Now, historically, we classified leg edema in 3 categories: venous edema, lymphedema, and lipedema. I used to take lipedema out of this equation because I feel lipedema is more fat maldistribution rather than true edema. So I still would argue, though, that there's 3 types of leg edema: venous edema, lymphedema, and combined venous and lymph. I feel like I was kind of onto something because, you know, what we once subscribed to, the Starling law of the capillaries, which was described way back in about 100 years ago in 1896. The Starling model proposed a fluid that would flow out of the capillary bed at the arterial end and be reabsorbed at the venous end of the capillary bed, and that only about 10 to 15% of the tissue fluid was drained through the lymphatic system. This held up for about 100 years. However, over the past 20 years or so, it's been revised for the 21st century. It is now thought that in most capillary beds, there is a net outflow of fluid all along the capillary bed, with no reabsorption at the venous end. So all capillary filtrate and tissue macromolecules are taken up by the lymphatic system. Tissue capillary beds rely on the endothelial glycocalyx, which is a hydrogel-like layer attached to the endothelial cell lining of the capillary that regulates protein concentrations within this layer, and it can move fluid between the intravascular and interstitial spaces. So by regulating protein concentration in the subglycocalyx space, this increase in opposition to filtration leaving the capillary along the venous end. You know, thus we see edema arising from capillary filtration that ends up exceeding lymphatic drainage. In other words, if lymphatic drainage is reduced and capillary filtration is normal, then edema results. So edema will form anytime capillary filtration exceeds maximum capacity of lymphatic drainage. You know, so one can really argue that all edema these days has a lymphatic component. And as Dr. Fernandez talked about this past weekend, all chronic edema is a form of lymphedema. So these changes really have been challenging our current way of classifying edema. Should we just classify edema as acute or chronic? Is there such thing as really primary and secondary lymphedema? I think there's a lot of overlap. Edema arising from venous disease is considered secondary lymphedema, although there's evidence of lymphatic failure in chronic venous disease with edema. Likewise, some forms of primary lymphedema have a venous component and a genetic predisposition to its development. So I'm sure this is going to evolve and new classifications are going to be formed in the near future. Chronic edema is defined as greater than 3 months. It's often multifactorial. Think of the elderly, immobile patient with dependent edema that also has heart failure, venous insufficiency, and is on amlodipine. You know, chronic edema now includes venous edema, lymphedema, dependent edema, and other chronic states of swelling as well. Failure in the lymphatic drainage is involved in all of these states of chronic edema. I used to categorize what causes venous edema versus what causes lymphedema. I think now that there's more evidence that there's a lot of overlap within these systems, but we're once thought we were more heavily dependent on the venous system to control the interstitial fluid volume. I think we're more dependent on the lymphatic system at this point. I think that's agreed upon. Now, if we put all this together, ingredients to prevent edema involve a good venous system, normal cardiac function, a healthy capillary endothelial glycocalyx, intact calf muscle pump, and also significant lymphatic assistance. So if we have any disruption at any of these, with any of these ingredients, edema will result. Let's briefly talk about the function of the calf muscle pump. Normally, and I tell my patients we don't have a heart in the foot pumping blood out of the legs, so we rely on muscle contraction and valves. We ratchet blood volume up out of the legs as we move and contract our calf. About 70% of the blood, leaves the leg with the calf muscle pump as it contracts. With muscle contraction, as we know, the majority of the blood leaves the leg through the deep veins. With muscle contraction, these deep veins are compressed, blood gets pushed up, valves close. With muscle relaxation, the deep veins or the deep vein valves now close. Other valves open in the superficial system, and we actually can suck blood from the superficial system into the deep system and have some filling. And then blood draws from the superficial veins and the deep veins through the perforator veins. Again, disruption in any point of this system can lead to edema. So when we evaluate clinically patients, there's a few things that I look at. I look at first, is the edema unilateral versus bilateral? Is the duration acute or chronic? Is it associated with any pain? And if it is bilateral, I start, really looking for more systemic symptoms. Not to say that I don't ask about systemic symptoms for unilateral edema. In some cases, like cellulitis, patients may get a fever. So it's still valuable to do a thorough H&P, obviously. But typically, I want to know, is it unilateral, bilateral? Is it acute or chronic? Is it painless or painful? And again, is there any other systemic symptoms that developed with any temporal relationship? So we had to generalize bilateral lower extremity edema is often chronic, often painless. However, chronic venous insufficiency, lipedema can cause some pain. When I was in residency in the emergency department, some of my attendings would say there's no such thing as a bilateral DVT. In practice, I've seen it. When you see this, think underlying malignancy. And then obviously for patients that have bilateral lower extremity edema, that's chronic, that's painless, and that are a little older, really ask about systemic symptoms. So systemic causes of bilateral lower extremity edema: heart failure. So again, dyspnea and exertion, just general fatigue, orthopnea, PND. You want to ask about all of this. You want to look for JVD, listen to the lungs. Pulmonary hypertension. These are our more obese patients. It develops with neck circumferences that exceed 17 inches. We also, cirrhosis and hepatic disease. Leg edema is more of a late finding in this. But keep it in mind. The other thing with hepatic disease, malignancies often migrate to the liver. So I have had a few of my physicians over the years diagnose liver disease as a result of malignancy. So keep that in mind. Kidney disease obviously can cause lower extremity edema and thyroid disease as well. Here's some signs of different disease states that can result in lower extremity edema. Pretibial myxedema, you see in the upper left-hand corner, spider angiomas, as well as medications that cause bilateral lower extremity edema, antihypertensives, hormones, and then even NSAIDs, which a lot of our patients are on. The incidence of leg edema associated with NSAID use is 5%. Calcium channel blockers and prednisone are actually the most common drugs that cause leg edema. ACE inhibitors are better than ARBs at reducing calcium channel blocker induced edema. So if you want to counteract some of that, and then the dihydropyridines like amlodipine and nifedipine more commonly cause edema than your verapamils and diltiazems. Let's talk real briefly. We talked about systemic causes, medication side effects that can cause lower extremity edema. But here's some common causes that we'll see every day in our clinics. Dependent edema. Patients that are obese tend to be a little bit more sedentary. So obesity in itself may cause a little bit of edema in itself, but these patients are more sedentary, so they have dependent edema. They also have sleep apnea. They also are typically hypertensive, so on antihypertensives. So the obesity state results in a lot of other comorbidities that can contribute to some lower extremity edema. Patients that are sitting all day. I don't know. I feel like with COVID, I saw a increase in patients with new lower extremity edema just as a result from sitting at home and working, from home, Zooming all day long. Also, I've had patients that will tell me they sleep in a recliner. So these patients oftentimes, develop significant bilateral lower extremity edema. Any patient that has a compromise to their calf muscle pump, patients with polio, stroke, things of this nature are going to develop some form of dependent edema. When we're evaluating younger women in the clinic, when they present with bilateral lower extremity edema, definitely ask if it's cyclic with the menstrual cycle. And then you can just reassure them that this is more hormonally driven. This is normal. They can utilize compression stockings during that period if it's really bothering them. Also with, women of childbearing years, pregnancy is something you got to think about. I still remember when I was in the emergency department and I had a patient come in and she was obviously pregnant, but she told me that she wasn't, and she just had some a stomach ache. And I'd actually print out a ultrasound picture of the fetus to prove it to her. So they may not think they're pregnant, but pregnancy obviously exists in this population. So the other most common cause of lower extremity edema in women in childbearing years is idiopathic edema. These patients are going to have lower extremity edema, but if you question them, they also may have concomitant edema of their hands. They may say that their rings get tight. They also may have some edema of their face as well. This type of edema is associated with obesity, depression, and also diuretic abuse. You can send patients to some nephrologists or primary care providers that do a water load test. And this is a test to more definitively diagnose idiopathic edema. Treatment starts with spironolactone because it's thought that idiopathic edema, these patients develop a secondary aldosteronism. So, and then patients with inferior vena cava thrombosis can also present with bilateral lower extremity edema as well. Now, in general, unilateral lower extremity edema is oftentimes more acute than bilateral. It can also be associated with more painful states like DVT, cellulitis, trauma, venous insufficiency, so chronic regional pain syndrome. Unilateral edema that's painless, think more lymphedema. Sometimes chronic venous insufficiency obviously can present without frank pain. You may get more of the restlessness, more of the itching and burning. And rarely do we need to look for systemic causes of unilateral lower extremity edema. So with unilateral lower extremity edemas, here's some common things that I think we've all seen in the clinic. Obviously, we all have to rule out deep vein thrombosis. This affects 1 out of 1,000 people per year. Patients usually present within 72 hours of developing pain and swelling. Again, surgery, trauma, hospitalization, travel, hormones, smoking, hypercoagulable states, family history, varicose veins, all predispose patients to developing DVTs. And we really worry about 3 things when we have DVT. We worry about the acute pain and swelling. We worry about it going to the lung and PE developing. We also worry about post-thrombotic syndrome, which we can see in up to half of patients with femoral vein DVTs. Superficial venous thrombosis. Again, this is, we used to feel that this was pretty benign and you just warm compresses, NSAIDs, compression, and it'll resolve on its own. We now know that, extensive SVTs or SVTs close to junctions with the deep system have a high likelihood of developing into DVTs. So in these cases, anticoagulation is warranted. Cellulitis and stasis dermatitis as well. Patients that have been admitted to the hospital with the initial diagnosis of cellulitis, about 1/3 of those patients, that initial diagnosis was incorrect. It ends up that 1/3 of these patients that was thought to have cellulitis actually have some form of stasis dermatitis, DVT, or atopic dermatitis. So keep all of those in your. Now, when it comes to painful unilateral leg swelling, obviously DVT, SVT, we just spoke about, but we also have to think about these acute things like ruptured Baker cyst, gastroc tear. And then more chronically, neuropathy can develop, resulting in foot drop and leg edema. We also know about the chronic regional pain syndrome, or RSD. So really question patients if they've had trauma to that limb in the past. That can give you some clues. More common causes of unilateral or bilateral lower extremity edema can present either with unilateral or bilateral, obviously lymphedema, lipedema, as well as chronic venous insufficiency and pelvic congestion or venous outflow obstruction. We can talk about any of these if you'd like to, but I think we're all pretty well versed after this past weekend with all of this. Now, just to generalize and to sum up what we've just talked about, typically unilateral edema may present a little bit more acutely and more likely to be painful. And we really need to rule out DVT, SVT, cellulitis, but then also keep in mind with painful unilateral edema, ruptured Baker cyst, gastroc tear, and even post-thrombotic syndrome as well. Typically bilateral, more likely to be chronic, can be painful, but not usually presents overtly painful. There's usually a combination of symptoms. And then the ones that present either unilaterally or bilaterally, lymphedema, lipedema, chronic venous insufficiency, and venous outflow obstruction. There's some rarer causes. I don't think we're going to be diagnosing beriberi in the clinic, but some other states of malnutrition and protein loss and enteropathy. Just keep that stuff in mind. When we see edema form from low protein states, usually this edema doesn't change much with dependence. So patients come in, a lot of times my lymphatic patients and venous patients will say, oh, I can see my ankles in the morning, but by the end of the day, they're swollen. You don't see that change in edema with a lot of these protein losing losses. So again, good history, age of the patient. The differential for women with childbearing years is different than a woman post. Think of trauma, both acutely as well as for chronic regional pain syndrome. Think of DVT and cellulitis. So we really need to not miss these more acute and urgent causes of lower extremity edema. In older patients with bilateral painless edema, always think about more systemic causes. Physical exam obviously can be important. Here's some skin clues that we can look at that can help us our diagnosis. Obviously, we've all seen the hyperkeratosis that can occur in some forms of lymphedema. We all know varicose veins and hyperpigmentation due to hemosiderin and melanin staining is almost pathognomonic for chronic venous insufficiency. This, if you get this really a patient that has a lot of discomfort in their leg, more warm, diaphoretic leg, very tender to the touch, think early RSD. We all know that the patients with lipedema, it looks like a swollen leg, but it typically spares the foot. It's like somebody put somebody else's foot on this swollen leg. And you can also look at swelling into the dorsum of the foot, usually represents some involvement of lymphatic impairment. We all know about the stemmer sign when we pinch the dorsum of the toe or the foot, and it doesn't. It kind of stays up. It tense, and then obviously warm, red, tender, really well demarcated an area represents cellulitis. We don't do much lab work in our clinics, which is nice actually, to be honest. But here's some lab work that can help if you're in the hospital or in a primary care setting that you may rely on to make a diagnosis. Imaging, I think that obviously the Doppler that we use is great first line tool to rule out not only common causes of leg swelling like venous disease, but also more urgent causes, DVT. We can use an MRV or an IVUS to evaluate suprainguinal and pelvic and abdominal clots. Echo, EKG, and chest X-ray if we're worried about CHF, pulmonary hypertension. Again, abdominal, pelvic CT, rule out malignancy. I think we all know that these tools exist and can be used if necessary. Now, a few recommendations for practice, largely based on just consensus, usual practice. MRV of the lower extremity and pelvis should be obtained in patients with unilateral swelling, and a negative duplex ultrasound is a high suspicion for DVT. Echocardiogram should be performed in patients with obesity, obstructive sleep apnea, and edema to evaluate pulmonary arterial pressures. ABI should be measured in patients with chronic venous insufficiency and cardiovascular risk factors before initiation of compression therapy. Now, I will one bit of advice in smokers. I tend to get ABIs for almost all smokers if I'm going to plan on putting them in stockings, or if I'm planning on doing vein closures where, they may rely on some of these conduits in the future. So I think it's important to get ABIs on smokers for both reasons. So daily hydration with emollients or short courses of topical steroid creams for severely inflamed skin should be used to treat stasis dermatitis associated with chronic venous insufficiency. Obviously, good skin care is important with any state of edema, especially with venous insufficiency and lymphedema. And obviously, pneumatic compression devices should be used in conjunction with standard therapy in patients with lymphedema. And compression stockings, this is kind of controversial after the SOX trial from about 2000, I think it was 2016, that showed that patients with DVTs, if you put them in stockings, that 14% of them actually developed post-thrombotic syndrome compared to 12% of patients that were not placed in compression stockings. I still like to use compression stockings for acute DVTs because I think it helps with some of the symptoms. I don't believe that compression stockings is a contributing factor to developing post-thrombotic syndrome, but this is something we can discuss more if anybody likes to. The basic treatment of lower extremity edema: compression, elevation, exercise, weight loss, monitor salt intake. So lifestyle changes. We should all be recommending these. These really don't cost much and are easy to do, and they often benefit the patient in more ways than just reducing their lower extremity edema. Diuretics are rarely necessary. Skincare is vital, as we just spoke about, and obviously let's identify the different causes and treat those underlying causes. Diuretics can be valuable in heart failure, renal failure, and sometimes liver failure. So we usually start with loop diuretics, heart or renal failure, and add spironolactone to these loop diuretics and liver failure, patients with ascites and lower extremity edema. Again, spironolactone's first drug of choice for idiopathic edema. And I think diuretics may give some short-term relief for patients with venous disease or lymphedema, but we really have to address the underlying issue, and I don't think they're necessary. So, real quick algorithm. We talked about somebody presenting with leg edema. Is it unilateral, bilateral? Is it chronic? Is it acute? Is it painful? Is it painless? These are all things that we should be considering. Again, bilateral edema, I can't emphasize this enough. In older individuals, just take that extra time to question them a little bit about systemic symptoms. I think it's very, very important. Some pearls. Thank goodness pelvic and rectal exams are low yield in patients with lower extremity edema. It's refreshing. Abdominal and pelvic CTs should be considered in patients over 40 without an obvious cause of their lower extremity edema, or younger patients with unilateral edema, pelvic signs and symptoms, and obviously looking for malignancy. And lab and imaging tests are appropriate in patients over 45 years old with bilateral lower extremity edema if they have systemic. So we'll conclude with a few pearls. Unilateral edema does not usually require an evaluation for a systemic source. So again, rule out DVT, look at the leg, rule out cellulitis. Your Doppler, look for venous disease, look for visual clues that there may be some lymphatic components. And if you're suspicious, look at the superinguinal, look for superinguinal disease. Those are the few things just to think about when we're evaluating unilateral edema. Edema associated again with decreased plasma, oncotic pressures, malabsorption, liver failure, nephrotic syndrome. Usually, as I mentioned, does not change with dependency. And the Doppler ultrasound is a perfect way to start to evaluate patients with all edema, especially unilateral edema, because we can rule out DVT, SVT, Baker's cyst, venous insufficiency. we get a lot done with this one test. Now, again, the most likely cause of leg edema in an adult over 50 is actually venous insufficiency, not heart failure. But you don't want to miss heart failure. So again, ask for systemic symptoms. I'll conclude with that.
So, thank you, Sean. So for the fellow Sager, I hope you realize how complicated leg swelling is, and that we should not just assume that all of it is due to venous insufficiency. So as an example, I mean, I recently had a patient who came in, obvious leg swelling, some beginning of class 4 disease, completely normal lower extremity Doppler. She then had a stress test and an echo with an ejection fraction of 53%. Her stress test was normal, but on her blood work, her creatinine was 1.5. She's African-American and her GFR was 30. So it's looking like her leg swelling is more related to the beginnings of renal insufficiency and some chronic renal. And when I spoke to her daughter, she said, "Dad, doc, it's been going on for about 3 years and it's progressively been getting worse." So I think this topic is extremely apropos. But Sean, I have a more practical question for you. So I see probably at least once a week a patient where the tech come to me and said, you know, Dr. P, this patient has pulsatile flow throughout their deep and superficial system. So how often is that associated or indicative of a right ventricular right heart failure, your experience?
Yeah, I think it's highly associated with that, to be honest. With, you know, a lot of these patients may have atrial fibrillation, but it may be the first signs of right-sided heart failure. So it's a good pickup. It's an easy pickup with the text, and it's something that should clue us into questioning these patients more and examining these patients a little further.
Yeah, you know, when I look at the literature on this, it doesn't have a high sensitivity and specificity. But again, if you put that finding in context with the talk that you just gave, and the patient has other risk factors that may be indicative of a more systemic cause, that's the patient that I think that you might want to consider for a bigger workup. And finally, I think the other takeaway message that I got from your talk today is don't forget about sleep apnea. I think we tend to poo-poo that as a cause of lower extremity edema because we think, well, it's just somebody who's snoring and they don't get some sleep. But the systemic causes of sleep apnea are real. And that was just a reminder for me. So does anybody else have any questions for Dr. Stewart?
Great talk, Sean. Thank you.
No, thank you guys for waking up early on this Friday and hanging out with me. I appreciate it.
Yeah. All right, guys. Listen, everybody have a great weekend. Wonderful seeing everybody last week, and we'll talk to you soon.
Thank you,
Sean.
guys.
Yeah.
Thanks.
Thanks, Sean.
Bye.
Take care.